Hello, everyone. Welcome to yet another episode of Retina Roundup. I am Dr. Yashasvi, Fellow in Vitrio Retina and Ocular Oncology, and I will be taking you through this month's top articles. The first article talks about the risk factors for proliferative vitreoretinopathy due to RRD. Total of 57,264 eyes seen in the last 7 years with the diagnosis of RRD with PVR were identified in the Westrum Health database. Variables were selected for univariate and multivariate analysis, and the incidence of PVR was determined within each subset of the patient population. Systemic factors found associated were younger age, female gender, smoking history, and hypertension. Ocular factors found linked to it were poor baseline visual acuity, history of ocular trauma, choroidal detachment, history of uveitis, giant retinal tear, pseudophakia, aphakia, and endophthalmitis. All factors were significantly and independently associated with increased odds of PVR development, hence implying that these factors must be kept in mind when planning surgical and therapeutic interventions for PVR prevention and treatment in patients with RRT. The next article we have aims at identifying optical coherence tomography based imaging biomarkers that can localize focal leakage points without fluorescent angiography in central serous chorioretinopathy. A total of 123 eyes with CSC between April 2018 to February 2024, comprising of 66 eyes with focal and 57 eyes with diffuse leakage, were studied. The leakage sites were assessed and OCT findings were compared between focal and diffuse leakage types. Hyporeflective lucency signs were observed in 27 eyes with focal type CSC, while no such sign was detected in diffuse type CSC cases. These signs were exclusively localized to leakage points with no occurrence in other areas within serous retinal detachment. Other signs identified in both focal and diffuse types were microribs of retinal pigment epithelium, subretinal hyperreflective material. The study concluded that hyporeflective lucency sign being present exclusively in the focal leakage points of fluorescent angiography may serve as a potential therapeutic target in CSC. Moving on. The next article explores the role of intravitreal clindamycin with dexamethasone as an adjunct to systemic cotrimoxazole and steroids in macular toxoplasma retinochoroiditis. 39 immunocompetent patients treated with combination of oral and intravitreal therapy were studied retrospectively. 5 lines of improvement in visual acuity on the ETDRS chart were noted at final visit. Hence, he concluded that intravitreal clindamycin with dexamethasone, when used as an adjunct to systemic therapy, showed resolution of retinitis in all cases with improvement in vision. The next article assesses the effectiveness of split thickness amniotic membrane grafts in achieving closure of refractory or large macular holes. This retrospective study reviewed data from patients who underwent surgical repair for macular hole using split thickness amniotic membrane grafts between January 2019 to December 2023. Key parameters including best corrected visual acuity and macular hole size were evaluated both preoperatively and postoperatively. They found that all macular holes were successfully closed and no intraoperative complication were observed. Significant visual improvement in BCVA from 20 by 200 to 20 by 400 of Snellen's equivalent was noted. Hence, split thickness amniotic membrane grafting is a safe and reliable option for closing refractory or large macular holes. Compared with full thickness grafts, split thickness amniotic membrane grafts offer advantages such as increased flexibility in placement and ease of removal post closure due to their thinner and more pliable nature. The next article investigates the surgical effect of complete drainage of suprachoroidal fluid before vitrectomy to avoid perioperative steroids in rhegmatogenous retinal detachment combined with choroidal detachment eyes. This was a prospective randomized controlled trial where 58 eyes were randomly divided into two groups, where Group 1 received a single preoperative periocular injection of methylprednisolone, while in Group 2, suprachoroidal fluid drainage was performed before vitrectomy. Follow up assessments were done up to 6 months. It was found that the post-operative retinal reattachment rates were similar in both groups. Improvement in BCVA, rate of inflammation, hypotony, incidence of macular chorioretinal folds, all were comparable in both groups. Hence, it was concluded that preoperative steroids may not be necessary for rhegmatogenous retinal detachment combined with choroidal detachment patients if the suprachoroidal fluid is completely drained before vitrectomy. The last article we have here reports the efficacy on the use of neodymium YAG laser in fragmenting dexamethasone intravitreal implant OZX migrated in the anterior chamber. Spontaneous migration of dexamethasone intravitreal implant into the anterior chamber can occur in patients with aphakia, prior pars plana vitrectomy, or compromised capsular support. In this interventional case series of 10 patients, they found that the Nd:YAG laser successfully fragmented the migrated implants in all cases without severe complications. No patient exhibited corneal edema at 4 months post treatment. Visual acuity remained stable or improved in 4 patients. In all patients, resolution of previous macular edema was detected. In this cohort, Nd:YAG laser appeared a safe and effective treatment option for managing anterior chamber migration of the dexamethasone intravitreal implant, avoiding the need for more invasive surgical techniques or temporary non-invasive techniques. Here's all for this month. See you all again in the next episode with another set of interesting articles. Thank you.